Welcome back to First Aid Neurology Review, brought to you by Falcon Physician Reviews. Horner syndrome. Horner syndrome is a triad of signs caused by a disruption of the sympathetic innervation of the eye. First, there is ptosis, which, in the case of Horner syndrome, is caused by weakness of the superior tarsal muscle. Therefore, the ptosis is weak. Second is anhidrosis, which is the absence of sweating or flushing of the affected side of the face. Third is miosis, or constriction of the pupil. These signs can be remembered by using the mnemonic, Pam is horny. Because the sympathetic innervation of the eye passes through multiple levels, there are multiple clinical conditions associated with Horner syndrome, such as Pancoast tumor, Brown-Séquard syndrome, which is a cord hemisection syndrome, or a late-stage syringomyelia. Shown here is a 3-neuron arc that is responsible for sympathetic innervation of the eye. The first neuron in the arc originates in the hypothalamus. The second is in the intermediolateral column of the gray matter at T1. And the third travels with the carotid into the head. As was shown in the previous slide, this 3-neuron oculosympathetic pathway projects from the hypothalamus to the intermediolateral column of the spinal cord, then to the superior cervical ganglion, and finally to the pupil, the smooth muscle of the eyelids, and the sweat glands of the forehead and the face. Interruption of any of these pathways results in a Horner syndrome. Certain dermatomes are particularly high yield, and it's important to know them cold, and it may be helpful to associate them with articles of clothing. For example, C2 refers to the posterior half of a skull cap. C3 corresponds to a high turtleneck shirt. C4 corresponds to a low collar shirt. T4 is at the nipple. T7 is at the xiphoid process. T10 is at the umbilicus, important for early appendicitis pain referral. L1 is at the inguinal ligament. L4 includes the kneecaps. S2, S3, and S4 are responsible for erection and sensation of the penile and anal zones. Diaphragm and gallbladder pain is referred to the right shoulder via the phrenic nerve. Now, there are a series of mnemonics that can help you remember some of these distributions. For example, T4 is the teat pore. T10 is at the belly put 10. L1 is at the IL, or the inguinal ligament. To remember that L4 covers the kneecap, you can use the mnemonic down on L4s, or all fours. And to recall that S2, S3, and S4 are for erection and sensation of the penile and anal zones, you can recall that S2, 3, and 4 keep the penis off the floor. There are some clinically important reflexes that you should know cold. These are: the biceps reflex tests the C5 nerve root, the triceps reflex tests the C7 nerve root, the patellar reflex tests the L4 nerve root, and the Achilles reflex tests the S1 nerve root. You can count these reflexes up in order: S1, S2, L3, L4, C5, C6, and C7, C8 as you're conducting the exam. The Babinski sign is dorsiflexion of the big toe and fanning of the other toes, and is a sign of an upper motor neuron lesion, although please recall that this sign is normal during the first year of life. In addition to the deep tendon reflexes, there are a number of so-called primitive reflexes that are present in infants, typically below 1 year of age, and some of them can be seen in adults during neurologic disease, particularly with frontal lobe lesions. For example, the Moro reflex consists of abduction and extension of the limbs when startled, and then drawing together of the limbs. In the rooting reflex, movement of the head is toward the side of the ipsilateral cheek or the mouth when it is stroked. This is thought to be nipple-seeking behavior. The sucking reflex is a sucking response when the roof of the mouth is touched. Palmar and plantar reflexes are curling of the fingers and toes when the hands and feet are stroked, respectively. And as mentioned before, the Babinski sign is dorsiflexion of the large toe and fanning of the other toes with plantar stimulation. Shown here are the major structures of the ventral side of the brain. For example, the roots of all the cranial nerves are shown here, as well as other major structures such as the cerebellum, the medulla, the pons, the midbrain, the ventral portion of the hypothalamus, the ventral portion of the temporal lobes, the ventral portions of the frontal lobes, the olfactory bulb, and the olfactory tract. On the dorsal side of the brain, with the cerebellum removed, we can observe the pineal body, the superior colliculi, the inferior colliculi, the superior cerebellar peduncles, the roots of cranial nerve 8, the base of the fourth ventricle, the medulla, and the middle cerebellar peduncles. There are several important clinical correlations to these structures that are seen on the dorsal surface of the midbrain. For example, the pineal gland is important for melatonin secretion and for the maintenance of circadian rhythms. The superior colliculi are important for conjugate vertical gaze. The inferior colliculi are a major relay station for auditory information. Paranode syndrome involves paralysis of conjugate vertical gaze due to a lesion of the superior colliculi, for example, due to a pinealoma. One way of keeping the superior and inferior colliculi straight is to note that your eyes are above your ears, and the superior colliculus, which is a visual structure, is above the inferior colliculus, which is an auditory structure. The cranial nerves are another high-yield topic on the USMLE. This slide summarizes the functions of the 12 cranial nerves. For example, the olfactory nerve is cranial nerve 1 and carries smell information and is the only cranial nerve without a thalamic relay to the cortex. It is purely a sensory nerve. The optic nerve, or cranial nerve 2, carries visual information from the retina to the optic chiasm, and it is purely a sensory nerve. The oculomotor nerve, or cranial nerve 3, carries eye movement information for the superior rectus, inferior rectus, medial rectus, and inferior oblique muscles. It carries information to the pupillary constrictors. These are from the parasympathetic centers in the midbrain, known as the Ettinger-Westphal nucleus, and the receptor type used here is the muscarinic receptor. This nerve also carries accommodation information, and it carries signals to trigger eyelid opening by innervating the levator palpebrae muscles. This is purely a motor nerve. The trochlear nerve, or cranial nerve 4, carries eye movement signals and innervates the superior oblique muscle. The trigeminal nerve, or cranial nerve 5, is important for mastication and facial sensation and has multiple branches, the ophthalmic, maxillary, and mandibular divisions, and this is both a sensory and motor nerve. The abducens nerve, or cranial nerve 6, carries eye movement information to the lateral rectus and is a motor nerve. The facial nerve, or cranial nerve 7, carries information for facial movement, for taste to the anterior 2/3 of the tongue, lacrimation, salivation via innervation of the submandibular and sublingual glands, eyelid closing via innervation of the orbicularis oculi, and finally innervation to the stapedius muscle in the ear. This is both a sensory and motor nerve. The vestibulocochlear nerve, or cranial nerve 8, carries information for hearing and balance, and this is a sensory nerve. The glossopharyngeal nerve, or cranial nerve 9, carries taste information from the posterior 1/3 of the tongue. It also is important for swallowing, salivation through innervation of the parotid gland, and for monitoring the carotid body and sinus chemo and baroreceptors, and for innervation of the stylopharyngeus, which mediates elevation of the pharynx and the larynx. This is both a sensory and motor nerve. The vagus nerve, or cranial nerve 10, carries taste information from the epiglottic region. It's also important for swallowing, palate elevation, keeping the uvula midline, for talking, coughing, and of course the vagus nerve innervates the thoracoabdominal viscera. It monitors the aortic arch chemo and baroreceptors as well. This is both a sensory and motor nerve. The accessory nerve, or cranial nerve 11, is important for turning of the head through innervation of the sternocleidomastoid muscles, and for shoulder shrugging through innervation of the trapezius muscles. This is purely a motor nerve. Finally, the hypoglossal nerve, or cranial nerve 10, is important for motor movement of the tongue, and this is a motor nerve. To help you remember the functions of all these nerves as being either sensory, motor, or both, one can use a mnemonic: some say merry money, but my brother says big brains matter most, to recall the sensory, motor, or both functions of these nerves. Another key component to understanding the cranial nerves is knowing where they emerge. For example, the midbrain is a source of cranial nerves 3 and 4. The pons is a source of cranial nerves 5, 6, 7, and 8. And the medulla is a source of cranial nerves 9, 10, 11, and 12. In terms of medial lateral, the lateral nuclei are derived from the alar plate and carry sensory information. The medial nuclei are derived from the basal plate and carry motor information. So try to remember M for both medial and motor. Several cranial nerves have testable reflexes. For example, the corneal reflex tests the afferents from the nasociliary branch of the ophthalmic branch of cranial nerve 5, and the efferent part of this pathway tests the temporal branch of cranial nerve 7 at the level of the orbicularis oculi. In addition, reflex lacrimation, not emotional lacrimation, has its afferent as the ophthalmic branch of cranial nerve 5 and the efferent branch of cranial nerve 7. The jaw jerk tests the mandibular branch of cranial nerve 5, both on the afferent and the efferent side. The gag reflex tests cranial nerve 9 on the afferent side and cranial nerves 9 and 10 on the efferent side. There are a number of brainstem nuclei that are important in controlling cranial nerve function. For example, the nucleus solitarius carries visceral sensory information, for example from taste receptors, baroreceptors, or for gut distension, and this information is carried through cranial nerves 7, 9, and 10. The nucleus ambiguus carries motor information, and recall the M in ambiguous and the M in motor, and this innervates the pharynx, larynx, and the upper esophagus. This is important for swallowing and for palate elevation, and the nerves that carry this information are cranial nerves 9, 10, and 11. The dorsal motor nucleus of the vagus sends autonomic or parasympathetic fibers to the heart, lungs, and the upper GI tract, and the cranial nerve that's involved here is the vagus nerve, cranial nerve 10. Another important set of clinical correlations have to do with which bony structures are associated with which cranial nerves. So for example, cranial nerve 1 emerges through the cribriform plate. The middle cranial fossa is important for knowing the emergence points of cranial nerves 2 through 6. This happens through the sphenoid bone. So for example, in the optic canal, we have cranial nerve 2, the ophthalmic artery, and the central retinal vein. The superior orbital fissure houses cranial nerves 3, 4, the first branch of cranial nerve 5, cranial nerve 6, the ophthalmic vein, and sympathetic fibers. The foramen rotundum houses cranial nerve 5, branch 2. The foramen ovale houses cranial nerve 5, branch 3. And the foramen spinosum houses the middle meningeal artery. One way of helping you to remember this is that the divisions of cranial nerve 5 exit owing to standing room only, the SRO. The posterior cranial fossa houses cranial nerves 7 through 12, and this is through the temporal or occipital bones. So in the internal auditory meatus, you'll find cranial nerves 7 and 8. In the jugular foramen, you'll find cranial nerves 9, 10, and 11, as well as a jugular vein. In the hypoglossal canal, you'll find cranial nerve 12. In the foramen magnum, you'll find the spinal roots of cranial nerve 11, brainstem, and the vertebral arteries. The cavernous sinus is an important structure because of its many clinical correlations. The cavernous sinus is a collection of venous sinuses located on either side of the pituitary and drains blood from the eye and superficial cortex and drains this blood into the internal jugular vein. Cranial nerves 3, 4, the first two branches of cranial nerve 5, and cranial nerve 6, and the postganglionic sympathetic fibers en route to the orbit all pass through the cavernous sinus. Only cranial nerve 6 is free-floating. The cavernous portion of the internal carotid is also found here. Note that the nerves that control the extraocular muscles plus V1 and V2 pass through the cavernous sinus. And one clinical correlation is the cavernous sinus syndrome, where there is a mass effect in the cavernous sinus. This can cause ophthalmoplegia and ophthalmic and maxillary sensory loss. Shown here are the components of the cavernous sinus. The cavernous sinus is bordered by the temporal bone, the sphenoid bone, and the sella turcica. From superior to inferior in terms of cranial nerves, we observe, first, the oculomotor nerve, the trochlear nerve, the abducens nerve, the ophthalmic nerve, which is a first branch of the trigeminal nerve, the maxillary nerve, which is a second branch of the trigeminal nerve. We also observe the carotid artery and the sympathetic plexus of nerves that surrounds it. There are multiple clinical correlations to cranial nerve lesions. For example, when there is a cranial nerve 12 or hypoglossal nerve lesion, this is a lower motor neuron lesion, one will observe tongue deviation toward the side of the lesion. One way of recalling this is that the patient is essentially licking his or her wounds. The reason for this is because this nerve is found after the decussation of the corticospinal tracts. Cranial nerve 5 lesions will cause the jaw to deviate toward the side of the lesion. It's because there is cortical input bilaterally to the lateral pterygoid muscle. Cranial nerve 10 lesions will cause the uvula to deviate away from the side of the lesion. It's because the weak side is collapsing and the uvula is pointing away from that side. Cranial nerve 11 lesions will cause weakness in turning the head to the contralateral side of the lesion due to weakness of the sternocleidomastoid muscle. There will also be a shoulder droop on the side of the lesion due to weakness of the trapezius muscle. There are also multiple neuroanatomical sources to hemifacial weakness. For example, an upper motor neuron lesion, such as that occurring in the motor cortex, or the connection between the motor cortex and the facial nucleus, will produce paralysis of the contralateral lower half of the face only, because the upper half has bilateral upper motor neuron innervation. Lower motor neuron damage to the facial nerve will cause ipsilateral weakness of both the upper and lower half of the face. A Bell's palsy is a classic lower motor neuron lesion of either the facial nucleus itself or its branchial efferent fibers. Clinically, these patients present with peripheral ipsilateral facial paralysis with the inability to close the ipsilateral eye. This can occur idiopathically, and most of these patients recover spontaneously. Other causes are AIDS, Lyme, herpes zoster, sarcoid, tumors, and diabetes mellitus. You can memorize this with a mnemonic, Alexander Graham Bell with an STD. You can test other cranial nerves by asking patients to make particular sounds. For example, k, tests palate elevation, and therefore tests cranial nerve 10, or the vagus. La, tests the tongue, which is cranial nerve 12 innervated, which is a hypoglossal nerve. Me, tests the lips, and therefore tests the integrity of the facial nerve. You can memorize this with the mnemonic that it would be a calamity to lose cranial nerves 10, 12, and 7. Mastication is a complex process, and 3 M muscles are used to close the jaw: masseter, temporalis, and medial pterygoid. Therefore, the M's munch. One muscle opens the jaw, and that's the lateral pterygoid. Therefore, the lateral lowers. Since it requires 3 muscles to close and 1 muscle to open the mouth, one might say that it requires more muscle to keep the mouth shut. All of these muscles are innervated by the mandibular branch of the trigeminal nerve. That concludes this portion of First Aid Neurology Review, brought to you by Falcon Physician Reviews.